Guys, good morning. Okay, guys, and good morning. We are live on YouTube, all right? And I would just request Arun to just verify if we are on the right channel. I would just request Santoshi to verify if it is visible on the phone. And guys, it is important that that we are coming in with PIP as far as this surgery is concerned. So the first step of any surgery is of course going to be mobilization of the sigmoid colon, and shown this to you multiple times. This is picture in picture. Vismay is assisting me. I have with me Saurabh sir, who is our anesthetist. Tanvi is on the trolley. I'm just holding on till Arun gives me all the confirmation. This is on advanced pelvic surgery and endometriosis channel. Arun, is that correct? Santoshi? And once I have the green signal from all of you, I will go ahead with the surgery, because this is an unmarried girl who has come to us with severe, absolutely severe pain in the abdomen, and you can see this. Yeah, you can see this, and along with that she also has an adenomyoma inside, which is a 3.5 centimeter adenomyoma, for which she has opted to undergo microwave ablation. And of course, here we go. So I will begin the surgery. I'll just actually wait for Arun to give me all the clearances. Arun? Yeah. Okay. Okay guys, good morning. I guess we are live on YouTube, Arun. Are we live on the endometriosis surgery channel? Okay guys, welcome here. So we can see that we are live on the surgical channel. This is a young girl who is a unmarried girl, and she has come to us with severe endometriosis, severe pain score of 10 by 10. This is important for you to know, that when pain score is 10 by 10, see, obviously by the time these girls will reach us, that means they have already been force fed everything. So this girl has already taken everything, right? Dynogest, elagolix. She also has an adenomyosis, and that is something where you have to be careful. When you have adenomyosis along with all of this, the outcome is going to be poor. There is a small endometrioma here, that was a hemorrhagic cyst, if you can see that. So I'll just rupture it, basically drain it, and just let it stay there. This is the posterior peritoneum which we have lifted. So now there is a lot of hue and cry as far as what we need to do about the peritoneum. So guys, you need to know and you need to understand very, very importantly this entire fact of life. Okay, see that this dissection, I am coming picture in picture, and guys, as you are aware, this is a picture in picture surgical event happening for you, so that it is on request basically of so many of you who are following us, our live surgeries. But you know, there are certain new policies which we need to stick to, and it's going to be our efforts always to get you know, to stick to those policies. This is where you see the entire problem is. See this, this is the part where the entire problem is. This is where you have a bowel nodule, you have a small sort of infiltration going on inside, all right. And the main problem, which of course a young girl like this one would face, who is unmarried, okay, is the capacity to bear the pain. So many girls do not have that capacity at all right. And you cannot really keep people in the pain just because you can't operate. So that is something which is not done. I know there are a lot of patients who are going to be joining this channel as well, because a huge request has come in from all the patients as well. So I am going to be answering the queries for patients as well as for my fellow colleagues. Important point here, I am using the sharer, and you can see I cut right in the center. I cut right in the center, center, open, gently. Now see this, the word here which was so important was to open gently, 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 gently. Yeah, the word gently I have used 5-6 times because in a super fast hand movement, majority of the bowel which was stuck here has been released. Now you know that the bowel is stuck here. When the bowel is stuck here, okay, I'll cut right in the center. You can use a cold knife scissor to cut, but I am going to be cutting right in the center. See that? Center. You can see that endometriosis is there. Center. Just coagulate that posterior endometriosis, and automatically the bowel has been set free. Down. The bowel here has been set free. 4 strokes and the bowel is down. Finished. Right? Now, what are you left with? Can you see here? You are left with this. Now, I do understand that plenty of people who do not understand endometriosis, and as a result of which, what will they do is that for such superficial disease, they will say that you don't have to do anything. Just be like that. But today, we have Vismay, and we will keep our ultrasound machine on, and we will try to demonstrate to you the infiltration of this superficial disease. We will try and demonstrate on how much it is invading in the bowel through a transrectal ultrasound. Now when we do that, the great advantage it offers to you as a healthcare practitioner or as a patient is to understand what are we trying to do in your situation. And that, in my humble opinion, is so important, because only when you follow that, you will be in a situation to follow everything else. So here we go. That is the separation of the complete ureter. Complete ureter nicely separated. This is the peritoneum, which I will remove because it is unhealthy. So now I do understand there will be certain people who will say that there is no guideline which recommends removal of the peritoneum. But we all know how guidelines are made. Guidelines are made by people who don't operate. So if in case you were to remove this peritoneum is going to show you 2 things. It is going to demonstrate to you a beautiful, and absolutely beautiful is the word, endometriotic lesion here. I will show you where it will demonstrate. Here, this is where the endometriotic lesion will be demonstrable, and it will of course demonstrate a lot of fibrosis. See this? This is where the endometriotic lesion is. So you could have said that why not just remove that much, and why remove the entire peritoneum and all these types of things. It doesn't really work that way, guys. You got to remove it off completely. Here, here, and here. Right? Now, this is the entire peritoneum which has come out. I am very happy with that. No problem. Before I go on to anything else, I have just verified this ovary. I will just look at the under aspect of the ovary. Yes, that's a hemorrhagic cyst. It looks good. That is where the ureter is going. I have infiltration in the peritoneum here. See this? I have infiltration in the peritoneum here. Okay, and the ureter is far away. This is, can you see this? See? Can you see that? Yeah. So for people, who are very gung-ho about doing a particular procedure and not knowing how to do, I hope this will prevent you the disappointment, because here, see this? Gentle. Your grasp on the peritoneum has to be very gentle. I'll also want to show you, this is exactly how early endometriosis looks like. So we will, because this is a open source channel, we will here be wanting to post very excellent information as to how the histopathology behaves for all these patients. You can see here, You can see here, see this is not endometriosis, but you can see here, this lesion had to be separated. It is infiltrating inside. If I come close, it is infiltrating inside and it will turn out to be endometriosis. Okay, surely it will turn out to be endometriosis. And don't worry, to the ones who love to challenge, we will be putting up histopath reports as well, so that science stays science for all of you, right? So here we go. The dissection seems to be good. The dissection seems to be done. The mobilization of the uterus is now excellent. Now, before I do anything else, before I do the microwave ablation, I can see this window, right, as I told you. So what I will do here, just gently, see my grasp is very gentle. I am not closing my instrument over it. I will separate, I will again grasp the fat and separate gently. That's the bowel, there. See that? No devascularization occurs in such a simple, gentle separation which you were to do for your patient. No, nothing happens. Okay, this is the bowel. I can palpate the bowel and I can feel the method in which the bowel is moving. There will be some infiltration inside this, right? I can just feel that, to be honest with you. So when I feel that infiltration, as I told you, we have two options. Either we do something called as deep shaving for this part, correct? Gently, I'll just separate here, very gently. Now, all the fat has been taken off. So now what is remaining is this. Can you see? All what is remaining is that part of the bowel which is projecting here with this little part of endometriosis. So I have two options. Either I can cut here, or I can do something. I feel this part is very hard. You can see the manner in which it is moving. Simultaneously, if it is involving the circularis muscle, I would want to do a discoid excision here. Okay, so let Vismay, can we have the probe which is covered with this thing, please? So I just wanted to know from Arun if everything is playing perfectly and if the audio quality and everything is good. Arun, yeah, great. So can we get the probes ready, please? Can we switch this? Vismay, can you just do a transrectal scan there? So Vismay is going to be doing our transrectal ultrasound, and when Vismay does the transrectal ultrasound, I want the camera to project only on the ultrasound. In the picture-in-picture, if you can close the video which is happening inside the abdomen, and you can project just on me or just on the ultrasound machine, it will be great. Because when you do that, I will be in a great situation to जो है इसमें बीटाडिन लगा दो उसके ऊपर. Is there a manner in which we can show just the scan? Maybe by switching the PIP, in a separate angle. So there is Vismay. I can see where he has come already. थोड़ुक बारे निकाल. बस ये point है. Here. If we can study the infiltration, I think it is coming. I can already see that spot. Aajo. Only black. Yeah. Yeah, Vismay. पाछड़ो. बारे आओ. This is the spot. और बढ़ाओ again. So this is something which we will do for every case where we check the infiltration before we do shaving or disc. There is an infiltration this way. And despite doing complete resection, if in case we leave this behind, okay, I will not be a very happy person. Plus simultaneously, I want to tell you very clearly, yes, you can do a deep shaving. You can. I can feel the nodule here now. And you can do a deep shaving there, but using a 29 number stapler in order to knock out that little tiny little disc, okay, is going to be very important. The disc is going to be less than 7 to 8 millimeters in size. The purpose is you can't leave this disease behind, and you cannot, yeah, go back to the normal screen, go back to the picture inside. The purpose is simple. You can't leave this disease inside and then say that, you know, I tried my level best. There is nothing called as trying your level best if the disease is remaining inside. Okay, you need to do a complete surgical thing. Only that little posterior relaxation is required there. See that? Don't do any much damage to the nerves there. Go gently, gently, gently. Just relax off that part of the bowel. See, it's a small window which we created there in the rectal mesentery, and just relaxed the bowel there. Just relax that little part of the bowel. No major things is happening from one side. Same thing you need to go and relax from the opposite side of the bowel as well. Just a very gentle relaxation, very gentle. No damage to any organ, as I told you, no major movements. Just do gentle relaxation. This relaxation alone is going to reduce the tension, just in case there is any which can occur over the suture lines, right? There are multiple techniques of knocking out a disc. I will show you the technique which we use the most commonly and the most standardly. But I want to teach everyone that this cannot be left inside. Yes, two options. You do a deep shaving if you want, or you do a disc if you want. As I told you, if in case there is depth, what we realize is that there is some depth beyond that as well. Just put a small disc and remove off everything, because yeah, inside, yeah, just put the inside part. Come, dalo. So you can see the disc is coming in. You can see the stapler number 29 just moving in. I can have the microwave probe, ablation probe ready, girls. See there it has come. See that we have opened the disc there linearly, and when you open the disc in linearity, that is the only part which I need to get covered inside. See this, that part here, this is that part which I have to get covered. So when I want to cover this entire part, I have two options here now. I can either take stitches on this. Come close, 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 close. रुको, थोड़ा सा लूज करो, क्लोज करो, अभी क्लोज करो, close, close, yeah, it's gone, right? So that part has come in the disc. When you take the disc, every other region, like for example the ureter is free, the ureter is free here, everything is good. I am like super happy on that. It's gone in nice and clean, and I will fire the disc. As soon as I fire the disc, I need to wait for around 10 seconds. This waiting for 10 seconds is damn important. It just allows the staple to get stapled very nicely inside. We are done with the 10 seconds. Yeah, we are done with the 10 seconds. I open up the stapling from there, and the staple just comes out. Now, if you look at this, and you know, we will show you the disc which has come out. So if Tanvi can show us the disc, see, just relax this part. Can you see this? Just relax this window. This is the window which you have to relax, and that is it. Automatically a good amount of relaxation will percolate down there. It just needs to be relaxed. Now, just in case you are somebody who is not very used to performing discs or these types of excisions, the principle of the repairs is so simple. Make sure all the time that whatever organ you have done, whatever repair is a relaxed organ, it's a tension free organ, nothing is there over that organ. You can see the bowel moving down so easily from that plane. You need to make sure of all these small things till the microwave ablation probe is getting ready. I want to show you the microwave ablation as well in this situation. So get the microwave ablation probes ready, girls. Here we go. Gentle, just relax this. That's what I was saying. just relax this window. So when it goes down now, the bowel stays completely relaxed. Now people can have a little argument here that if you were to do a deep shaving, you know, this much amount of relaxation might not have been required. I do not agree to that, guys. Even if you were to do shaving, I will probably suture it also, okay, because I have seen enough complications of people who have shaved and then there is a complication out of it, right? So we have seen enough, and I think it is important that follow sound, simple rules. Do not sort of alter the rules for anything. See, this excellent relaxation has been achieved now. I am not at all worried about this plane now. It's a good relaxation already. It's a good relaxation of the bowel. You can see some very mild amount of tension there. Nothing I'm going to be doing on that. Chhod do. It's already like this under a head low, so she'll do fine. Yeah, she'll do very well. Give me a probe. Here we come with the microwave ablation probe. Microwave ablation probe, I know many people again have advocated to do it transvaginally, but our mapping has been already performed. Keep it at 60 watts and keep it for 3 minutes. This is where her pain is. We have already loculated the lesion. This is exactly where you go. This is 2 centimeters. This is the 3rd centimeter. That's it. So when you loculate the lesion nice and clean, start. When you loculate the lesion nice and clean, it's easy. Rectal probe dal do rectum mein. By the time the ablation is happening, we will pass a rectal probe through the rectum just to make sure that our anastomosis is good. Just see that everything is good there. I am not worried. Yeah. So guys, with this, pass. Yeah, thank you. With this, the surgery would come to an end after the microwave ablation is done in the next 2 minutes or so. Of course, I will encourage each and every one of you to ask your questions. I'll be very happy to answer your questions. I welcome you all again to the live sessions, and let's hope we keep them as interactive as it was on Facebook. And let's hope it really benefits each and every one of you. You have got to be very careful when you are doing microwave ablation. No damage should occur to the endometrium. No damage should occur to the serosa. Those things are important. We will be removing the specimen which we have generated here. Okay, the specimen retrieval is going to happen through our standard 5 mm port. There is a small area of, and God bless you. Thank you.